And I will introduce Dr. Bauer and then turn the evening over to her. So Dr. Jennifer Bauer attended Brown University for undergrad and Case Western Reserve University for a dual medical and Master's of Anatomy degree. She completed her residency at Vanderbilt Medical Center and spent a year in pediatric orthopedic fellowship at Nemours Al DuPont Hospital for Children, where her time was focused on care of the pediatric spine. Her elective practice at Seattle Children's is entirely devoted to spine care, treating patients of all ages and conditions, from common to rare and complex. She holds several leadership positions at the hospital, including spine division leader and fellowship director. As a member of the University of Washington orthopedic faculty, she is committed to mentoring med students, residents, and fellows to become the next surgeon leaders. She also serves as invited faculty for national and international educational courses. Dr. Bauer continues to dedicate time to orthopedic research to improve the field of spinal deformity and pediatric fractures, and often presents her work at national and international conferences. She is a committee member of the Pediatric Spine Societies and study groups, has earned several traveling fellowships, and is an editor and reviewer for scientific journals. Outside of the hospital, she enjoys most water and outdoor activities, including wing foiling, wake surfing, cycling, and skiing. And with that, I will turn it over to Dr. Bauer.
Great, thank you so much for the introduction. Good evening, everyone. Thanks for joining us. I do want to let this be as interactive as possible. I'm happy to stop at any point and take questions. I can see chat. I don't actually know how many people are on here this evening, especially if it's a small group. Happy to cover all, any questions that you want, related or completely unrelated. I am a spine surgeon that does everything, head to toe. And so we cover a lot of different things here. The most common things that I think you guys normally see is AIS type surgery, and we've had a couple talks on that. And so I wanted to talk and at least give some sort of a primer on non-adolescent idiopathic scoliosis and how to tell the difference, because I think that's the key point to all of this. So we'll go through this and talk about some other types and cover from there. So the different types we'll talk about, how to recognize them, and then different treatment strategies for some of them, and why and when to refer. So it's helpful to compare to probably the most well-known things, which are idiopathic scoliosis. So in idiopathic scoliosis, adolescent idiopathic scoliosis, it's a curve that's diagnosed after they're 10 years old of at least 10 degrees. Now, the key point here is that it's a 3D difference. It's a 3D deformity. And all three of those deformities have to be present for us to be very confident that it's an idiopathic scoliosis. And that's the key driver that makes me think that maybe it's not idiopathic. So we'll start talking about that in a second as we talk about the other ones. But the three main deformities in adolescent idiopathic scoliosis is one, just the front view, the coronal curve that you see, that you think about, that parents think about. That's the curve that we're measuring in a Cobb angle. And then on the side view, they're lordotic, or they're hypokyphotic. So that thoracic spine on the side view should be coming out much more. And then they also have rotation. So you can see the difference in the rib hump on that lateral radiograph. You can also see it on an AP radiograph if you're really looking closely at the pedicles. And so our treatment for this is not just fixing this front view with some screws and rods, but we're really trying to fix the sagittal profile. We think that's what's going to change then the patient's quality of life for the rest of their life. So you can see here on the side view, that's actually when I show an x-ray to a fellow surgeon, if I show them the front view, they'll say, yeah, what are you trying to hide? If I just show them the side view, they're actually never even going to ask for the front view, because what we should be concentrating on, if you are truly doing the research on pediatric orthopedic or pediatric scoliosis, is this side view. So if you do a lot of these, if your career is dedicated to these, you're going to care about the side view. So you can see here on the side where we gave this patient more kyphosis. You can actually see how the preoperative lateral view has kyphosis in the cervical spine, which will become a problem later on in life. And now that's starting to straighten out better because we gave kyphosis back to the thoracic spine. All right, that's AIS. It can, if it presents at a different age, we're talking about infantile, that's less than 3, juvenile 3 to 10, or over 10, adolescent, 10 or over. There's a lot of different categories for non-idiopathic. Syndromic, we're going to go through. Neuromuscular, we're going to go through. Congenital. Scheuermann's kyphosis, I didn't talk about much in this talk, but that's when they could have some scoliosis, but really the difference is on the side view, they have kyphosis. The normal amount of kyphosis is up to 40 degrees. So this is over 40 degrees of kyphosis with at least 3 vertebrae that have wedging of at least 5 degrees if you measure just the end plate to the end plate of the vertebra on the lateral radiograph. And that itself can cause some back pain, can cause some trouble later on in life, but it's something that we largely treat with physical therapy. I'm only going to offer surgery on this if it's well over 80 degrees and this patient has tried everything they can to avoid a surgery for that point. They also have thoracogenic scoliosis, so that's usually something going on in the chest. Either they've had a chest surgery before, so it's kind of tethering inside their chest as a young child, or they have rib fusions, or they've had a big heart surgery that's maybe affected the way that the soft tissue, the discs, the tissue overlying the spine, and the spine itself is going to grow for the rest of their lives. Lots of different non-idiopathic. There's also another category that actually fits into these two categories, and that's early onset. So early onset scoliosis is a curve less than 10 degrees. So juvenile idiopathic scoliosis technically fits in that. So does infantile. But you can also have a congenital, neuromuscular, or a syndromic scoliosis that just happens to happen early on. So they're all treated in different ways. First, we're going to discuss non-idiopathic neuromuscular scoliosis. This is the second most common scoliosis that we see. I'm not sure how much of this walks into your clinic, particularly with some of the main causes of scoliosis that we think about. Cerebral palsy, myelodysplasia or spina bifida, a tethered cord, spinal muscular atrophy, Duchenne's muscular dystrophy, or Rett syndrome. So these are all patients that often are already going to have these diagnoses, except for tethered cord, I'd say. You already know about this. You're already seeing these patients. They're pretty complex. I don't know how complex your pediatric clinics and practices are, but these are some pretty complex kids. If you're taking care of these, that's wonderful. They can be a challenge, but nearly all of these are going to expect to have a curve at some point. The ones that are hiding that you actually need to make sure you notice, separate from AIS, are going to be things like tethered cord or Chiari and Syrinx. This is a basic neuromuscular scoliosis compared on the right to an AIS. So it's not a very balanced S-shaped curve usually. So it's a little bit more C-shaped. So that's one thing you're going to notice. They might be standing far off to the side. They don't have the same typical hypokyphosis. Their lateral radiographs could show anything. Their pelvis is tilted. You can see they have pelvic imbalance. It's a pretty big curve. And some other things that give this away is there's some other things usually on the x-ray. A G-tube, a shunt, a VNS, lots of different things that a baclofen pump that you could notice just showing us an x-ray might make us say, this is probably neuromuscular. But really what you should be thinking is it's not that balanced. It's not a nice balanced S curve or triple curve. It's usually more of a C-shaped curve. It can be an S curve. So this is a pretty classic neuromuscular curve. Contrast that to this curve. This is a 14-year-old who has this curve. Again, think about these three planes of deformity, excuse me. You have the classic AP on the right. You can see that's a kind of an S-shaped curve. It's kind of a short, quick curve, though. We would call that a short, sharp curve, a little bit dystrophic. To be 80 degrees and only be over about 5 levels, that would make me start to think maybe something's going on. And then the lateral makes me think maybe something's going on. There's kyphosis here. I'm thinking, is there a bone that's shaped a little bit differently? And maybe that's why it's kyphotic. Could this be a congenital curve that I just can't see? Or is there something else going on? Does this kid have any sort of syndromes that I already know about? If not, well, a kyphotic curve for me is going to get an MRI every time. The other thing you might start to do is, well, we're going to look at some flexibility before we take this curve to an operating room. This is a 78-degree curve. A curve over 50 in a growing child is definitely going to be offered a surgery. You can see on these flexibility curves, it really doesn't get very straight when they bend all the way to the right on the right side. So I'm thinking maybe something's going on here. So I'm going to get an MRI, and this is what the MRI shows. So the MRI shows a Chiari here. So this is technically, you know, you could call it like a neuromuscular scoliosis. The thing that distinguishes neuromuscular scoliosis from adolescent idiopathic scoliosis is we know the cause of neuromuscular scoliosis, and it's that the brain doesn't talk in the same way to the muscles as it should. And so there's an abnormal balance of the way that the muscles move and that the torso sits upright and that everything isn't as coordinated and balanced out. That's why we get this C-shaped curve. That's why they're out of balance. That's why their pelvis can be tilted. That's why things don't act quite the same way. They might have some findings on their x-rays. These are some exam findings or some x-ray findings that would make me get an MRI. If they're having base of skull headaches, that can be typical of something like a Chiari, even if their x-ray looks like a typical AIS patient. Any abnormal neuroexam, so any asymmetry in their reflexes, any hyperreflexia, those would all make me on an exam get an MRI. And then on the x-ray, that short, sharp curve I showed you, being imbalanced off to the side pretty far, and an incorrect three-dimensional deformity. So they don't have rotation or they don't have kyphosis. All those things would make me think, all right, I think I'm going to get an MRI. Maybe there's something else that I'm going to find. Maybe it's going to be this subtle neuromuscular, and just like a less subtle neuromuscular, a subtle neuromuscular, so less subtle meaning GMFCS5 neuromuscular cerebral palsy, but a less subtle finding of neuromuscular scoliosis. These two are going to be pretty similar because we don't know how they're going to act, or we can't say that just when growth ends, maybe this curve is going to stop getting bigger, like we can tell adolescent idiopathic scoliosis patients, because the signal is always going to be on to be abnormal, whether it's spasticity or whether it's just this delicate imbalance of the dorsal columns, which is going to control the proprioception of their truncal muscles, making them be a little bit more off balance and have more likelihood of a curve or a progression or a curve that progresses even when they're done growing. That's why it's important to make this distinction. And it's important because this patient is going to get a Chiari decompression before we take them to surgery. So that's how I'm going to help try to decide between neuromuscular scoliosis. I'm going to put some things in some gold boxes here to hopefully emphasize some points. All right, another form of non-idiopathic syndromic. Again, a lot of these kids are going to come in with diagnoses already, but it might be subtle that you might not pick up. These are the typical syndromic diagnoses that we see that are common to have scoliosis. So any sort of connective tissue syndrome. So if you have this loose tissue and you have some overgrowth in the anterior part of the spine, which we think might be what leads to adolescent idiopathic scoliosis, and then it causes this rotation, there's not going to be as much balance to hold on to the spine and allow that to keep progressing. So if someone is really loose, has a lot of flexibility, and a connective tissue disorder, we're concerned that these curves are going to be more likely to progress. So Marfan's, we see a lot of scoliosis, neurofibromatosis, and I think that's really the effect of these neurofibromas that are sitting right next to the spine, causing differences in the way that the spine grows and the way that all of the body reacts to that. Prader-Willi, pretty common for us to see. That's more of a hypotonia issue. Turner syndrome we see often, and any other sort of chromosomal difference. I see a new microdeletion chromosomal diagnosis in clinic probably every day. And certainly, as you guys know, the parents are the experts on these. I can Google the diagnosis before I go in, but some of these are just so rare, and I just ask them to tell me about the diagnosis, because oftentimes they're certainly going to be the experts about them. So any sort of a difference that's going to give them something where I could say that they have some syndromic aspects to them, that's going to be a syndromic scoliosis to me. And so
Dr.
basically,
Bauer.
yeah.
Oh, we had a hand raised, so I was hoping I could
Oh,
interrupt
yes.
you for a second to have Joe Montgomery. Sorry, I just realized your hand was raised. I think it's been there a little while, but I'm going to go ahead and unmute you so you can ask your question.
Joe, are you there?
Joe, I think you may have to accept a request to unmute yourself. We rarely do this, so apologies for any technical difficulties. Oh, the hand got lowered. So,
Okay, maybe we answered it.
yeah.
Feel free to
Okay.
raise again or type in the chat as well. All right, so syndromic, no diagnosis curve. That's a syndromic scoliosis. All right, so here's another example, case example. This is a patient with a 31-degree curve. I've got the hand x-ray there because we know from idiopathic scoliosis that we can use the hand growth plates for the Sanders score to determine where they are in their stage of growth of their spine and how much more rapid growth they probably have left. This, I don't know if it comes out very well, but this is just a Sanders 3. So lots of growth left, RISR 0. Triradiates are not even quite close. They're closing, I would say. 31-degree curve is normally going to be something that we would offer a brace for. Growing curve over 25 degrees. See how it kind of looks C-shaped though? It's not really this balanced S. On the lateral, we've got rotation. We got this rib difference. I'm going to expect that. It's a bit of a normal kyphosis. It's probably between 10 and 40, so that would be normal. A little bit more kyphosis at the top, but that's okay. In the front view, though, there's very little rotation. The pedicles are staying pretty symmetric all the way up. So this is, and she's kind of off to the side. This is one that I would think probably needs an MRI. Another thing is this patient came into our emergency room, and the father said, I swear 2 weeks ago she was not like this. She did not have this curve, I swear to you. And for our team that was seeing this patient that doesn't normally see spine and isn't as accustomed to that, they were thrown off by that. You know, you can know how many times you see a patient and they say, I swear this just showed up, but probably it was there a while. And so that's kind of what our team thought until they showed it to me. And I said, you know, there's really not that much rotation. Because of that, I would definitely get an MRI. And maybe there's something to this. Father is also a physician, was like, hey, sounding the alarm bells. This is not, I swear my kid was not like this. So we got an MRI, and this is what the MRI shows. You can see hyperintensity on this T2 image on the sagittal spine throughout here. A little bit in the body. This ended up being just a vascular anomaly. But you can see this along the posterior aspect. Same thing here. And you can see all this edema in the surrounding musculature. So we're worried about this. And if you have an astute eye, you can pick up that there's this kind of central lesion right here. So that to me is pretty classic. And I think I can see it a lot better on a CT. So we got a CT, and CT confirmed what our suspicions were, which is an osteoid osteoma. And so this is something we would call an Olisthetic curve, a curve that's caused from pain from something. So the body is moving itself away from this painful stimuli, and in doing so, creating this curve. But because it's not from this overgrowth or a difference in the discs, it's actually not doing that same sort of rotation that we see in a lot of idiopathic curves, and it's just kind of moving out of its way. And so a curve without rotation, you should really get an MRI and think about what else could be going on. Now, a 20-degree curve, you're not going to see much rotation, right? So if it's a small curve and it doesn't have a rotation, sure. But that's certainly why we're happy to see any of these patients and really decide. Because to go on to an MRI, especially in these young kids, that's a lot. We don't want to be ordering MRIs for kids that we don't need to, but maybe some of these things, if you're monitoring some of these kids and you think, I don't know, maybe someone else should take a look at this x-ray. We're happy to see these kids and decide even if they should be getting MRIs. So this kid got, actually we were able to radio frequency ablate him because actually it was just far enough from the cord that I and our interventional radiologist felt comfortable. Otherwise, we'd have to go in and curate that out. And it's part of a facet joint there, and then we would have had to effuse. So we were able to just do a quick procedure, and this kid got a lot better, and the curve came back over. Here's another example. Just a 10-degree curve. Things look a little weird though, right? Kind of that shift over, not a lot of rotation. On the lateral view, it looks really flat. I'd be happy for someone to yell out if they see something, but if, I don't know, if we're not doing so well at unmuting or if it's a challenge, take a look and see what you see here for a second. What you notice is if you look all the way down at the L5S1 area, It's actually a pretty big slip, a pretty big dysplastic spondylolisthesis. And so the body's kind of trying to create a curve sort of against this pain, and then it's also trying to catch itself, so the pelvis is becoming very flat and retroverted, and so that's why overall the spine has really lost its overall sagittal alignment. Very odd sagittal alignment there, all in response to this. So this patient, again, I would call this an Olisthetic curve, even though it's a small curve. It's really that lateral view that looks odd. So this kid gets, we can reduce this safely, slowly. Take off the disc, take out the parts of the bone to try to get it to reduce back against those nerves, put in a cage and fuse just a single level fusion even for this big curve. So again, the reason that we thought that in these last two examples also we would want to get an MRI, or we think maybe this is an AIS, is because there was incorrect three-dimensional aspects to it. No rotation, more kyphosis, really flat, just looks odd to you. Something looks a little bit odd. Certainly want to keep in mind the other exam findings. Any questions before I start talking about some early onset scoliosis? We're gonna have a lot of time for questions here. All right, we'll keep going here. Moving on to early onset scoliosis. So a curve that's less than 20, that's any curve that occurs in a patient less than 10 degrees, that's at least 25 degrees. That's something that I would have you refer to us, because these kids should get an MRI. Any curve in a 10-year-old less than 25 degrees should get an MRI, because study shows a third of these kids will have some difference found on their MRI, whether it's a Chiari, a syrinx, a tethered cord, neurofibroma, something going on. So it's a pretty high rate. And then when we talk about this to have a long MRI, now we're talking about they're probably going to need a sedated MRI. And then there might be other tests that we want to order while they're already sedated. Do we need to look at their kidneys, their heart while they're there because they have a congenital deformity? Because a congenital spine problem, we also need to make sure that they don't have kidney problems or heart problems. Do we want to get some sort of lung studies? What exactly is caused by this early onset scoliosis, and then where do we go from there? So early onset scoliosis is something that I would want to see sooner than later. All right, so that's kind of how we start to see and what I'm looking at when I look at x-rays and when I'm examining these patients, and how I can tell, or what makes me nervous that maybe this is an idiopathic scoliosis, so we don't miss it. Now, when we talk about treating them, the whole purpose that we want to make sure that we know what the cause is because we might be treating these differently. For idiopathic scoliosis, our treatment goal is to stop the progression before adulthood. I want to see if I can keep this curve as small as possible for as long as possible till they're done growing. Then it's just up to gravity and we see what happens, but I want to try to avoid surgery in these kids. But the reason we operate if the curve gets up to 50 is because that's one that's going to keep likely progressing throughout the rest of their lives. And we know that at 60 or 70, it's actually going to start to cause respiratory symptoms. And so the reason we care about idiopathic scoliosis is the respiratory function. When it comes to non-idiopathic scoliosis, our sort of one of the main treatment goals is to make sure we're even knowing what the diagnosis is so that we can treat it the correct way, because there's so many different types of non-idiopathic scoliosis. We need to make sure we do the correct diagnostic tests so that we can treat it the right way. Non-idiopathic scoliosis, as you see here, is a large spectrum. So it might be very AIS-like, and it might be treated just like AIS, maybe if there's just a syrinx, or after we decompress a Chiari, or after we decompress, or after we release a tethered cord. Or it could be very different. It could be the other end of the spectrum, spina bifida, which is a very different approach within the neuromuscular, even separate from cerebral palsy, neuromuscular scoliosis. So we want to figure out what they have so we know how to treat them. And then we want to improve their daily function and how they're interacting with their world. And if they're really high functioning, then we're going to be treating them like AIS because there's not much we can do more to improve their daily function. But if they have a hard time sitting up in the wheelchair, they're falling over, they're getting a lot of pneumonias, they can't go to school. Well, now we're aiming to get them to have better lung function, to be able to go to school, to be able to sit up and interact with their family appropriately. And then when we think about early onset scoliosis, we're doing everything we can to try to preserve their respiratory function. We want to fuse as late as we can. We want to fuse as short as we can early on. We want to do everything we can to delay surgery in them as well. And there's lots of different options for these kids to try to avoid doing all that stuff. So when we talk about these specifically in treatment, we've already gone over neuromuscular scoliosis in a number of talks. Happy to talk about that more, but you guys probably have a good sense of that. For neuromuscular scoliosis, the question becomes, well, is there a role for non-operative management? If we saw a 35, 40 degree curve in an AIS kid, we're going to give these kids, especially if they're still growing, we're going to give them a brace to try to control their growth. Well, a neuromuscular kid is still going to grow as well. So they have growth that is adding into this signal that's incorrect, that's abnormal, that's imbalanced, that has spasticity and tone problems to it. So should we be bracing these kids? Well, when we look at studies, we show that perhaps bracing helps with really low tone kids because it helps them sit up better. It helps their stability and their ability to sit. But neither of these studies showed, and these are such old studies because they proved to us really early on that these kids don't get they don't avoid surgery by having braces. Braces don't prevent them from progressing on to needing a surgery. And so we use it almost symptomatically as a way to try to help them interact with the world and help their overall daily life. Now, for some kids, they already have a bunch of braces, and having one more brace actually makes more of a burden on them and their family. So I tend to use a wheelchair modification a little bit more to have these kids help sit up and interact. Lateral side supports are key for these kids, and I basically use those as like a 3-point brace for them and hold them in their wheelchair that way. We can always go to a brace though as well if we need to, but it hasn't shown the avoidance of surgery. So there's not a lot we can do for a lot of these kids, especially on the other end, on the high end of the neuromuscular scale. How about when they're really young and they have big curves, like when we do for idiopathic juvenile and we were treating them with growing rods? Well, we actually know from, again, early studies that the rates of complication are so high in these kids, and some studies have gone to say specifically, we do not recommend you use growing rods in these children. And for me, I will try to avoid using growing rods at all costs in these kids because of the high rates of complication, which means we don't have a lot to do. And we're trying to say, all right, well, when do we fuse? If all I have is a wheelchair, maybe a brace that we don't think works, what do we do? Well, when it comes to idiopathic scoliosis, again, we know that the pulmonary decline happens over 70 degrees. And so for these kids, we're going to operate on them when the curve's over 50 or over 45 if they still have a lot of growth left, or do growing rods if they're really young. And we're caring about the size of the curve and the growth that they have remaining. For neuromuscular scoliosis, we're thinking about how they sit, how they digest, how they breathe. We know that they have much higher complications if we wait, if the curve is over 90 degrees, and they have much higher complications if we do a growing rod. And so our aim is to try to be in the sweet spot between those. Wait till they get old enough to not need growing rods. So they're still going to be young, but not 90 degrees. So the curve is going to be big. So we'll wait for these curves to get bigger if we need these kids to get larger and have more growth in their chest. So we're going to treat their signs and symptoms and avoid complications. Intraoperatively, we have to make a lot of different approaches between these two patient populations as well. Idiopathic patients have really good bones, their curves, we often will get to them when their curves are not over 90, and these kids really care about how they look, and so we're really trying to correct all this 3D deformity, especially with any waist or shoulder imbalance. And if we don't have neuromuscular signals intraoperatively, we're definitely going to abort. With neuromuscular scoliosis, they have poor bone. It's like putting screws into a drywall instead of putting screws into a 2x4. You can kind of rip them out, so you have to be more gentle. Therefore, you probably can't correct them as much. Their curves usually start off bigger to begin with, but what we're really focused on is getting that pelvis flat and getting a nice sitting balance for them. So we use a lot of other things during surgery, and we prepare them for surgery differently. So here's an example of neuromuscular scoliosis where we're going to fuse all the way down into the pelvis to get them a stable base to sit on, as this patient that we showed earlier. Because we do surgery younger on these kids than we would for idiopathic scoliosis, we would like to see them sooner, even when their curve isn't that big, because it's usually a lot to prepare these patients because they're often very complicated and complex. They've had a hip surgery or they've had a lot of other things going on. We'd rather start to talk to them and get them ready about this idea of a surgery sooner, because what often will happen is they get to us, they get referred to us at maybe a 40-degree curve. By the time we see them, it's 60 or 70. And now we're telling the family they really want surgery, but it's too much for them to absorb and understand. And they need to go home and think about it. We lose them. Now they come back, it's over 90, and it's a very, very different procedure for the family and the patient. So we want to make sure we start talking to them sooner. For syndromic, again, I talk about it's a very big spectrum. So when it comes to treating these patients, it's very individualized. They can be on the AIS end of the spectrum. They can be on the heavy involved neuromuscular spectrum. And we've got to think about what's best for each one of these patients as we consider what's the cause. Is there a different way to treat that cause? Do they need medical management of their NF first? Do they need physical therapy to help their hypotonia first? Different ways to approach these kids based on which syndrome is causing their scoliosis or leading to their scoliosis. When it comes to Olisthetic curves, we're treating the painful cause. So we want to see them so that we can figure out how to treat it and what exactly is going on. And then early onset, because we can treat these kids as early as 12 months, we really want to see them early because their outcomes actually depend on how early we start treating them. And these can be variable causes for early onset scoliosis. So variable problems, lots of different ways we can treat. This first one on the left, it's actually an idiopathic scoliosis. We can brace these kids. We can cast these kids or brace them. We have better results curing their scoliosis perhaps with a cast, but we need to start it before they're 2 years old to have the best chance of curing it. This kid went on to cure after a couple casts. The patient here, this is a syndromic patient who refused to wear a brace. It's a very big curve, 70 degrees, but too young to fuse. So she's going to get growing rods. She got magnetically controlled growing rods here. We were able to get a good result with that. She went on to eventually get a final fusion. She had these growing rods for 4 or 5 years. So we're able to delay surgery. And then the third one on the right, this is probably a 3-year-old who had a congenital scoliosis, just a hemivert that we went and just removed the hemivert, treated just with a single fusion at age 3, so that we can straighten her out and only fuse a single level there. And then, of course, we have some much, much more complicated early onset kids, such as these two different kids here that take a whole different approach, that we're talking to our partners all around the entire country to figure out how to help these types of kids and these challenges. So big range of problems, big range of different types of scoliosis, and I think we're happy to treat all of them here. This is our team here. We have 3 spine surgeons. All we do are spines, these 3 groups here, these 3 surgeons. We also take call and see fractures and do basic things like that. But our practices really are focused on spine. Our research is focused on spine. Our involvement around the country is focused on spine. So we're happy to be resources to you all however we can, and we're happy to see your patients. And if you ever have trouble getting someone in or you have a question, please feel free to reach out, email us. We have centralized scheduling, and anyone who has that knows that can be a challenge, but we don't want it to be. We're very accessible to you, and would like to make sure your kids are being taken care of. I'm happy to answer any questions about anything about spine that anyone would like.
Don't see any questions just yet. I am going to go ahead and pop a link in the chat for the evaluation. And so people can fill that out if they would be willing to do so. And with that, just as a reminder, if you have a question, you can either put it in the chat. Oh, we have a question. Are we able to see different exam findings with these?
With these? Yeah, good question. So not always. The things that you will see to trigger it will be maybe some hyperreflexia, complaints of headaches. You shouldn't really have headaches when you're coughing or jumping up and down, or tussive headaches, we'll call them. That's going to be certainly more from, I'd be worried that there's something like a syrinx. Hyperreflexia, maybe a cord tether. Those are kind of the subtle ones that you don't want to miss. And then for syndromic things, do they have a little bit of a delay? Do they walk a little bit differently? Are their arches really collapsed? Is one arch high and one arch collapsed? I found a tumor in the spine once that way. Any asymmetry, left versus right. So some things can be pretty subtle. A fairly big curve and you do an Adams for a bend test and it seems pretty flat. That's one way to see also that there's not the rotation that you might expect. All right, bunch more questions. Here we go. Do you see benefit in PT for adolescents with small curves? I see the benefit of physical therapy in two ways. One, standard physical therapy, core strengthening, back, abs, hamstring, focus there, I think really helps mechanical back pain or periscapular. I think that really helps mechanical back pain, someone who's maybe a little deconditioned. We know that having this curve does lend itself to more pain, not in all kids, but in some kids. There's a lot of things, as you guys know, that are playing on these pain pathways, but I think that physical therapy can really help. Schroth physical therapy, totally different. While it can help a little bit with some pain, really the focus there is to teach these people to hold their spines straight in a way almost like their curves were braced. So in just the same manner that I wouldn't give a brace to a 15-ish, 10, really small curve because there's not something enough to push on, I wouldn't give physical therapy to a really small curve because it's not enough that they would benefit from it if they're not having pain, or if there's not really much of a curve to learn to hold open in a certain way. But young curves, around 20 or 30 degrees, that's like the perfect sweet spot probably for some Schroth physical therapy. Oh, good. Thank you for bringing this up. What about left-sided scoliosis? Do you tend to MRI these kids and only if there are neuro findings? Great question. So a lot of basics of who gets MRIs is actually dictated by some of it can be dictated by the legal culture of the region. So my colleagues in New York City will not take a single patient to the operating room, even your most standard basics 50-degree AIS that watched along the way without an MRI. Here, I think we're much more conservative about, or you could call that conservative and us maybe more aggressive to not get MRIs. But I tend to feel more comfortable, I think, than other partners in other areas, not necessarily getting an MRI if the exam is normal. Some relative reasons that some of my partners have here too of getting an MRI is a left-sided curve. Now, if it's a lumbar curve, it should go to the left. If it's a high thoracic curve, it should go to the left. But a main thoracic curve to the left, that could be a reason to get an MRI. Those are commonly seen in thoracogenic scoliosis. So if I know you have something going on with your heart or your lungs, I'm probably not going to MRI a left-sided curve, but nothing else going on, big left-sided main thoracic curve, I may get an MRI for. And another reason that's relative is something that's very pure AIS in a boy. Some people will do it in a boy because it's so much less likely for a male to need surgery for AIS compared to a female. But I guess anecdotally, I've seen it much more on a neurodivergent pathway for or a spectrum for male. So like teenage AIS male patient, curve large enough to have surgery. It's not too uncommon that I see maybe some autism or some other neurodivergence in those patients, but those might be someone that will get an MRI on as well. Next one, do all cases of spondylolisthesis require surgical correction? You have a cheerleader currently started on PT, assume she may end up needing surgery. So the kind of dogma around this is a low grade slip, grade 1 or 2, so 50% slip or less, doesn't progress on to a high grade slip. Now that's crazy to think, right? How do you get to high? You have to progress through there at some point. But the thought is that it happens faster or earlier than you ever have any symptoms. And if you're having symptoms and you get an x-ray and you're at 1 or 2, then it's most likely a low grade slip that's going to stay low grade. So these might have surgery, but only for symptoms, only if they fail everything else. It's not a fusion that we like. We just don't like to do fusions as kids if we don't have to. And the majority of these will get better with some PT, maybe a brace or some rest. High grade cheerleaders, they're pounding that area there, linebackers, gymnasts, that extension motion is going to kind of really push that and perhaps lead to a lot more pain. So I will certainly try physical therapy and do everything I can to avoid that. This kid actually had a domed sacrum, so it was actually already a grade 4 slip, totally imbalanced in the lumbar spine and already a high grade slip. So high grade slips technically also don't all need surgery, but they tend to have a lot of nerve root symptoms, and that's why we operate on them.
All right. Thank you, Dr. Bauer. I don't see any more questions in the chat. I don't have any raised hands. So I think we may be all wrapped up for tonight. So thank you, Dr. Bauer, so much for that talk. It was great. I know we've gotten to hear you talk about AIS, so it was really fascinating to hear about some of these other scoliosis conditions you see in clinic.
Yeah, thank you guys for coming. Thanks for your work too. I recognize a lot of names here of some people that you know, that we share patients with. So thanks for trusting us with your patients. And if we can ever help you, if we ever fall short of your expectations, let us know. We're just all in this together and want to make sure we're treating your patients well.
All right, thank you, everyone. We hope to see you at our next CME, and we will send a follow-up email in about a week with materials, links, a link to the recording, etc. Have a great evening.
Thanks, guys.